Is Dr. Naman? Yeah. So Dr. Naman is going to talk about characteristics of myelinated retinal nerve fibers and associated with Shatner syndrome. Slides, please. Slides, please.
I'll be talking about characteristics of myelinated nerve fibers in associated Shatner syndrome. The most common ocular syndrome linked to myelinated retinal fibers are Shatner syndrome. It is characterized by unilateral MRNF, axial myopia, amblyopia, rarely associated with strabismus and nystagmus. MRNF is rare congenital anomaly appearing gray-white opacification with feathery margins in superficial retina, which leads to obscuration of the retinal and the choroidal details. In our study, the primary goal was to analyze MRNF cases continuous with the optic disc and study the relationship with axial elongation and visual acuity. The study's design was retrospective observational case series in a tertiary eye care in South India. The inclusion criteria was MRNF continuous with the optic disc, which was confirmed by a fundus examination and imaging. And exclusion were isolated MRNFs and poor quality images. The test we used was Shapiro-Wilk for normality and Spearman correlation test for MRNF size, visual acuity, and refractive error. On ocular findings, we calculated the visual acuity, refractive errors, and the intraocular pressure. In the MRNF characteristics which we noted was type, which was 1A was superior, 1B superior plus inferior, and 1C was the inferior one. The size was measured using the optomap, and the posterior staphyloma was also seen. This is a type 1A case. Type 1B with superior and inferior MRNF, and type 1C, which was inferior. Using an area automated measurement tool, we calculated the area of the MRNF. Why the study was done? This study aims to fill the lack of large-scale MRNF case series in the recent literature. It explores the correlation between the MRNF size and the visual impairment. It improves the understanding of MRNF and its impact on visual outcomes, and it provides insight into the pathogenesis of Shatner syndrome. On result, we noted that there was total of 19 eyes in 18 patients in which bilaterally it was present in one case. The median visual acuity logMAR was 0.4. The median intraocular pressure was 13.5. The most common type of MRNF, which was noted as 14, and the mean size was 34.37 plus minus. There was no significant correlation which was noted with MRNF size. Axial elongation may not be uniformly affect the refractive error. MRN weakness retinal structure, as the larger MRNF can lead to greater elongation and amblyopia and poor vision. This was a chart which showed the correlation of the MRNF with visual acuity and the refractive error, where the refractive errors was not significant with the MRNF size. In conclusion, the MRNF size does matter, as larger MRNF can correlate with poorer visual acuity. Shatner syndrome is the most common association with MRNF, characterized by axial myopia and amblyopia. For clinicians, MRNF size can help predict visual outcomes, and early management of amblyopia is crucial. For researchers, further studies with advanced imaging are needed, and larger cohorts can validate these findings. These are my references. Thank you.
Thank you, Dr. Naman.